Without further ado, the next speaker is Dr. Shauna Morrissey, one of my partners, who's going to be talking to you about circulation.
We're going to talk a little bit about hemorrhagic shock and shock in general. Okay, so now your patient has been intubated. So you did your chest stuff. A chest tube has been inserted. So there's a small air leak, a small amount of blood in the tube. There's a large scalp laceration. He has blood pooling on the gurney. Abdomen you see is distended. The jeans are blood stained and his blood pressure remains 70/30. So at this point, what is your role in the management of shock? And this is what the lecture is going to go through right now. So we're going to recognize what shock is, list some potential causes in the trauma patient. The biggest cause obviously is going to be hemorrhagic shock. So we'll identify and control any bleeding. We'll initiate the resuscitation as a team, identify and understand the need for early transfer. So always in the back of your mind when you're seeing these patients, anyone that's unstable, anyone that comes in with any significant trauma, you're always going to have in the back of your mind of how and when you're going to do the transfer process. So shock is defined as the inadequate blood flow to meet the metabolic needs of cells. And this could be from a lot of different causes, but this is just a generalized definition for what shock is. So how do we recognize this? Now, is it okay if I ask questions then? So can someone tell me just some ways to recognize that a patient is in shock? Okay, but I can't see how you do. All right. Okay, sorry, I'm getting used to this Zoom stuff. You know, I like to be a little bit more interactive. So signs of shock. First, you're going to see an increased heart rate. Now, in any patient population, except for the geriatric patients that may be on beta blockers, you're typically going to have, that's the first thing you're going to have, is an increase in heart rate. Now, when you look at pediatric patients, they may lose a very large amount of blood before you're going to see any hemodynamic instability because they have just a great ability to compensate. So you have to look at other clinical signs and look at the clinical scenario and the injuries that you're dealing with, because you may not see, they may look good, and all of a sudden they're not good. So you just always have to have in the back of your mind, you know, and heightened response and awareness of these things. They could have anxiety or altered mental status. Now, again, when you look at the geriatric patient, like with the heart rate, like I said, they may be on beta blockers or different medications that could decrease their response to hemorrhage or to shock. So anxiety, altered mental status, some of them have underlying delirium, or I should say underlying dementia, you know, delirium, different types of things, could be on medications that are going to alter their mental status. So you have to keep those things in the back of your head when you're seeing these patients. Decreased capillary refill, very easy to do on your physical exam. And decreased urine output. So if you do have a Foley catheter in, urine output actually is a great way to assess the response of your resuscitation and your treatment of the patient's shock. So if you do have that ability, definitely put a catheter in, that way you can monitor the response. But again, signs of shock may be misleading. In those patients that are older, they're on beta blockers, they may mask any tachycardia they're going to get. Patients come in, I mean, you know, a lot of trauma patients, actually at one point they were saying that over about 40 to 50% of patients that come in with traumatic injuries actually are intoxicated or on some sort of drugs. So drugs, alcohol, head injuries, those things may all cause altered mental status. However, we know that hemorrhagic shock, once you start seeing the patient be altered, you know that you're getting to a higher level of shock that you need to be resuscitating sooner than later. Some laboratory tests that can be useful adjuncts, if they're rapidly available, obviously, are base deficits and lactates. Now, the initial base deficit and the initial lactate can give you and you know, have you kind of think that, okay, maybe the patient is in shock. But more importantly, we utilize these things at tertiary care centers to follow them. So we follow the lactate and use that to guide our response. So that while that number may give you an idea of, hey, this patient has an elevated lactate, they may be in shock, they may be hemorrhaging. I would say there are also an abundance of things that can elevate that lactate. So anyone that's hypovolemic because of, you know, alcohol, because of some medications that they take, they could have elevated lactates. So you can use these things, but I would not use these things and only these things to guide your, or to diagnose shock. So after you identify shock, so then you want to determine the cause. Most trauma patients are suffering from hypovolemic or hemorrhagic shock. Not all, and we'll talk about some of the other causes of shock later on in the lecture, but you always have to think that shock is hemorrhagic until you can prove otherwise. So treat these patients as if they're actively bleeding. During your primary survey, it's going to include identification and control of life-threatening external bleeding. So things that we teach in they stop the bleeding course. So you identify the bleeding, you're going to put direct pressure, you're going to try to stop that bleeding the best you can. If you have things like quick clot or any type of hemostatic agent, you can utilize those to pack the wound, to wrap around the wound. And then in extremity bleeding or places where you're able to put a tourniquet, if everything else fails, then you can utilize a tourniquet. So those will be in your primary survey. Audible bleeding you deal with in the primary survey. So when you look at sites of life-threatening blood loss, there are only certain number of body cavities that you can lose enough blood in, to cause someone to die from blood loss. The first thing is going to be your chest. So the way that you're going to look at your chest, and during your secondary survey, you're going to do adjuncts such as a chest X-ray. So all trauma patients, should really be getting a chest film and a pelvic film. And that's, I should say, all unstable trauma patients. So those are easy things that you can do, and any hospital system has the ability to do that. So you're going to get your chest film and you're going to look for blood in the chest. The second site of life-threatening bleeding would be your abdomen. Different ways to evaluate the abdomen would be a fast exam, if you have an ultrasound readily available. And if you have somebody there at your facility that could potentially deal with life-threatening bleeding in the abdomen, then it makes sense to do a fast exam. A pelvis X-ray. So the third place to look for bleeding is pelvic fractures. Pelvic fractures can give you a significant amount of blood loss. And with the way that you would manage that is if you get the X-ray, you see a pelvic fracture, wrap a sheet, or if you happen to have a T-pod available, go ahead and wrap the pelvis and try to control the hemorrhage in that way. Extremities, we talked about that a little bit. Fractures, so femur fractures, you can lose at least 1 liter of blood into the leg cavity there. So you can get a significant amount of blood loss from fractures. So identifying these and stabilizing them the best you can is extremely important. The last thing is externally. We don't know, you can lose a significant amount of blood at the scene. That's why it's really important to talk to your pre-hospital providers to say, how much blood loss was there? Was it a lot? Was it a little bit? Look at the gurney, look at the patient's clothing to see if it's saturated, because you can lose a significant amount of blood from our patient that we talked about at the beginning, like a scalp wound. You can lose a significant amount of blood and die from blood loss from a scalp wound without really seeing too much when you first look at it. Now, it's not necessary, to identify the exact source of blood loss unless you have a way to control it. So you don't want to do unnecessary things like CAT scans if it's going to just make the transfer process longer, if you're not able to immediately deal with it. As I said before, if you have a general surgeon in your facility that would feel comfortable taking a patient's spleen out, then by all means, try to find where that blood loss is. But if you don't have those capabilities, then be thinking about transfer earlier than later. So for chest bleeding, so as you can see here on the X-ray, on the left side of the X-ray, which would be the right side of the patient's chest, you can see that white area on the lower portion of the chest. So this is just showing you that there's hemorrhage there. The first thing that you're going to want to do if you see a hemothorax like this would be to place a chest tube. And that can immediately evacuate that hemothorax. And then with that chest tube too, you can also evaluate how much blood is coming out. Now, thankfully, bleeding in the chest and blood loss in the chest, most of the time, chest trauma does not need the operating room. And you can do different things like resuscitative measures or placing chest tubes to actually control this, and they don't need operative management. And then you're going to resuscitate after you place the tube in this patient. You would resuscitate as you would for other forms of hemorrhagic shock, which we'll get into, such as your fluids and your blood products. So when you think about abdominal bleeding, you're going to look at your physical exam. So if you see distension, things to make you think that maybe they're bleeding. So if you see distension, if the patient is tender, if they're awake and alert and they're able to tell you they're tender, take it seriously. Any bruising. So seatbelt signs can be if a patient comes in with a large seatbelt sign, there's a very good chance that they may have some internal bleeding that you're not aware of from the external sites. So again, further workup for abdominal bleeding, unless you have a surgeon or unless you have somebody available to actually act on those findings, it's really not recommended to do any further workup. So basically, you don't want to delay transfer to image the abdomen, especially if you don't have a surgeon available. If you do have a fast exam and you're not delaying transfer, you can always utilize that if you have those capabilities to have an idea of where the blood loss is coming from. But again, you're just going to resuscitate them the way that you normally would resuscitate a bleeding patient. So when we talk about pelvis bleeding, your physical exam findings could include bruising, stability of the pelvis. You always want to rock the pelvis, feel if it feels stable. I'm not going to lie, so sometimes that can be very difficult, and it can be a very difficult physical exam to perform. And I've had patients that have had unstable pelvis injuries that on exam you really weren't able to tell whether or not it was from their body habitus or their mental status, but it can be very difficult. But those are the things that you want to do, because if you find them, then you can say, okay, this may be coming from the pelvis. So we would recommend getting a pelvis x-ray. Things that you're going to be looking for are fractures, widening of the symphysis, the pubis symphysis. And if the patient is hemodynamically unstable and you find a pelvic fracture, then that's when you're going to want to put a binder in place. Now, not everyone has the binder that you see here in the picture. It's like a teapot, what we would call a teapot. Not everyone has that, and it's okay to just use a sheet or something to that effect to be able to tighten down and help try to control that bleeding from the pelvis. So as far as extremity bleeding, anytime you see a fracture, like I said before, you can lose a lot of blood into a femur fracture, a humerus fracture. You could lose up to 1 liter in that. So when you find these, you want to reduce them and splint them to the best of your abilities. Now, one exception to that is if a patient does have a femur fracture, but they also have a pelvic or tibia fracture on the same side, then we recommend not splinting those or not putting them in traction. Now, you can splint them to the best of your ability, but I would not put that patient in traction. Again, with extremity bleeding, if you find someone that has obvious audible bleeding from the extremity, you always want to hold direct pressure first. Utilize your packing and your hemostatic agents if you have them second, or you could, even if you don't have the hemostatic type of agents, you can hold a pressure dressing in place and wrap it as tight as you can to help control that bleeding. And if those things don't work, then the last thing you would do is to place a tourniquet. Again, sorry to go over that again, but so again, external bleeding control with direct pressure. If it can't be controlled that way, you may require a tourniquet, like in this picture here. There's really no way. This is such a big wound here, and it's a partial, well, I should say a full amputation of the upper extremity. So you may have a hard time, getting direct pressure and controlling the bleeding if there is bleeding. But that being said, not every patient that has this type of injury needs a tourniquet. Right, if you have bleeding that can't be controlled, then obviously put the tourniquet up. It's very important that when you do place a tourniquet, you always want to mark the time that it was placed. So then that way we know when the patient gets to the tertiary care center, we know when, the timing that the tourniquet was placed. Bleeding from scalp lacerations, again, can be life-threatening. They can be controlled with things that are easy, things that most emergency departments will have, such as staples or sutures. I like to staple these if I can, just to control the bleeding first. You can always go back and later on take the staples out and reapproximate those edges and do those things that you need to do to make it look nice. But to control the bleeding, I find that staples can help, pretty quickly. So when we talk about resuscitation, the first thing you're going to need to do is get adequate vascular access. So you're going to want 2 large bore IVs, about 16 gauge or larger. You can look to interosseous access in adults and children also. So And interosseous access is actually is gaining popularity now because we know it's a very good way to access prior to putting in central lines or things like that, especially in children where central lines can be a lot more difficult. But you can get the same amount of blood flow, sometimes better actually, with interosseous access as you can with central lines. If you're going to do the IO, the best place actually to put it, you're going to get the highest flow rates and it's going to get to the heart the quickest is going to be the humerus if you can. But, you know, in trauma patients, sometimes it can be difficult with different fracture sites and things like that. But definitely, if you have an IO, don't be afraid to use it. And it can definitely give you good enough access to resuscitate the patient. Again, central lines, saphenous cut downs, they can be used not very often. I think that I did one saphenous cut down in, you know, my 8 years or so of between my training and now. So it's not going to be utilized very often, but it is a maneuver that you can do if you have to. But I would say at this point, honestly, the biggest or the most common type of access, if you can't get, you know, large bore peripheral access, is going to be the IO. So to start, you know, with this course, they're teaching, you know, starting your resuscitation with fluid boluses. So they're saying 1 to 2 liters in adults or 20 cc's per kilo in children. What I would say is that if you have the patient, if you have, you know, a bleeding patient in front of you, you know that they're hemorrhaging and you have blood available, I would utilize blood prior to utilizing any crystalloid solutions. Now, that being said, I understand that a lot of smaller hospitals may not have access to blood and blood products. So you may want to start with this initial 1 to 2 liters of warm to make sure that if you can, it can be warm saline because you don't want the patient to get hypothermic because that'll just make your bleeding worse. So initial bolus 1 to 2 liters of lactated ringers if you have it. You know, we typically will use LR as opposed to normal saline just because of the volume of normal saline that you sometimes need. You're going to get an acidosis because of the chloride, and that'll worsen your bleeding and get you into that lethal triad of bleeding. So the goal is really to keep a systolic blood pressure of about 90. Sometimes what we'll say is that the patient is awake and alert and talking with you, they're good. If you have a good radial pulse, they're good. You don't want to over resuscitate them, especially in the bleeding patient, because if you're trying to push that blood pressure up and blowing all these products into them, number one, you're going to make the end result of the resuscitation worse. So the complications and different things that can happen. Number two, you're going to be potentially causing an increased bleeding because as you elevate that blood pressure, what can happen is you can actually increase the bleeding. So the only patient population I would hesitate though is if you do have someone that has a head injury, you don't want to utilize this mechanism of resuscitation. You always want to make sure that their blood pressure is over 90, usually over 100 if we can, because we know that if their systolic blood pressure is less than 90, their mortality rates increase dramatically. But if you have an isolated, extremity injury that's bleeding, your goal should be a systolic blood pressure of around 90. Now they're saying, if no response to crystalloid, switch to blood transfusions. However, like I said before, if you have someone that's actively bleeding, I would advocate starting blood prior to any crystalloid. Again, blood transfusion, if they only respond transiently to your fluid, always give O negative until you have type specific or cross-match blood. Now, if you do have if it's a male patient or a woman that's over childbearing age, it's okay to use O positive blood for those patients. But any female of childbearing age, you really want to use O negative if you can. If you can't, give the O positive, but it'd be better if you can give them the O negative. So when we look at blood component, resuscitation, truly what we're finding now is if you have the capability of giving whole blood, which a lot of places don't at this point, but once those capabilities are available, whole blood is really the way to go. Packed red blood cells, that's most places will have at least a couple of units of packed cells. We can, use those. The problem with the packed cells is they don't contain coagulation factors. So truly, if you're doing a resuscitation, the way that we should, you should be giving FFP and also platelets to these patients. So once you give about 2 packs of packed red blood cells, you really want to start giving FFP in a 1-to-1 ratio, as close to a 1-to-1 ratio as you can. Now, we understand that a lot of smaller places in rural communities that you may not have any FFP, or you may have one of FFP in the whole hospital. So don't withhold giving blood if you don't have the FFP. But if you do have the ability, try to stay to that 1-to-1 if you can. Again, warm all your fluids, warm all your blood products. We want to try to keep the hypothermia and the acidosis to a minimum. There are 3 types of responses you're going to get to resuscitation. There's going to be your rapid responders. You may give 500 cc's to a liter of fluid or a unit of blood, and they're going to rapidly respond. These are the patients that are more than likely going to do okay, either without any intervention, or they'll be okay enough to get them to somewhere that can intervene. Your transient responders, those are the most tricky of the groups. They're going to be the patients that you give blood to, and oh, they look a little bit better, then wait about 10 minutes later, they look a little bit worse. Oh, we give them blood, they look a little bit better. So, these are the patients that are a little bit more tricky. And then there's going to be the non-responders. Now, the non-responders are going to be the ones that are going to die quick. They're going to need actively resuscitated. They're going to have intervention as soon as possible in order to survive. So rapid response responders, again, vital signs normalize with the 1 to 2 liters, maybe a unit of blood. Your blood loss is going to be very minimal, about less than 20% of the total blood volume. And sometimes in these patients, you may not even need blood products. You give them some fluid and they're fine. Again, the transient patients, these ones, they're going to respond initially. You can say the blood loss volume is around 20 to 40%. Blood products are typically going to be needed, and the patient likely is going to need some sort of operative intervention. And again, like I said, these patients are the tricky patients. Once they come to us, they're the ones that, okay, do we sit and watch them? Do we take them to the operating room? I think, out of all 3 groups, these ones are going to be the most tough to definitively manage. And then there's your non-responders. You're never going to get normal vital signs. You're going to have a tremendous amount of blood loss. You're going to need large quantities of blood products, and the patient's going to have a extremely high likelihood of needing operative intervention, and an extremely high likelihood of non-survival or mortality. So we say, the most common cause of shock in trauma patients is going to be hemorrhage. You always have to exclude hemorrhage as a cause, but that doesn't mean that there aren't other types of shock that the patients could come in with. Obstructive shock, I know you talked about tension pneumothoraces and cardiac tamponade in the earlier lecture, but these things, you have to remember that these things can coexist with hemorrhagic shock. So you always want to be looking at these things and rolling these things as you go out. Neurogenic shock, this results from complete or near complete spinal cord injury at the cervical or high thoracic levels. You're going to have a resultant loss in your vascular tone. And the patients most of the time are going to be relatively hypovolemic, or they're going to appear that way because of this loss in vascular tone. You can have a coexistence with hemorrhagic shock, and it can be very difficult to diagnose these things. I've taken patients to the operating room because of thinking that most of their shock was from bleeding in their belly, and here they have had C-spine injuries causing the shock. Now, if you have true just neurogenic shock, you're going to give them the fluids and try to resuscitate them that way. And then depending on the location, depending on the severity, they're ultimately probably going to need some sort of pressor support. But you want to make sure that you make these patients euvolemic first. Cardiogenic shock. So patients that have severe blunt cardiac injury can have cardiogenic shock. It is pretty rare. And most patients that have a blunt cardiac injury don't end up developing cardiogenic shock, but it can happen. You want to suspect it with rapid deceleration injuries and any heavy blows to the chest. And then, when you have a high geriatric population like we happen to have here at our trauma center, you always worry patients could potentially have had MIs or had medical emergencies prior to being involved in their MVC. So they can come in with strokes. Lots of different things that we'll find. So a bad MI could cause a cardiogenic shock. And again, like it says here, any pre-existing conditions can also coexist with any type of hemorrhagic shock that you have. So when you're looking at shock and your treatments and your diagnoses, there's always going to be some pitfalls and some things that you have to pay particular close attention to. You don't want to rely on your blood pressure only to diagnose shock. There's a lot of subset of patients, young healthy patients can sustain a lot of blood loss before their blood pressure drops. Patients that are elderly may have a higher blood pressure to begin with. And so if they come in with a blood pressure of 90, then that's a significant drop in blood pressure. Excessive use of crystalloid when you actually need blood. As I said before, if you see someone with audible bleeding, I would go straight to blood if you have the resources available. If you use a lot of crystalloid, you're going to end up with a hypothermic acidotic patient, which is going to worsen your bleeding. And over resuscitation to a quote normal blood pressure, Dr. Dumar will tell you there is no normal blood pressure. So you don't want to over resuscitate the patient. Try to make sure that they're awake, they're mentating, and keep their blood pressure at or around 90 if you can. Again, if you have a patient that has a severe head injury, that's the type of patient that you definitely want to keep their blood pressure probably over about 100.
So now you get to ask questions.
Any questions? No questions for me? Oh, okay. So I'm going to ask you questions. Then you can ask me questions. So the most common cause of shock in the injured patient is A, cardiogenic, B, hemorrhagic, C, neurogenic, or D, septic. Okay, so it looks like I did my job and the majority of you got it right, and it's going to be hemorrhagic shock. So the injured patient, first thing you rule out, most common cause of shock is going to be hemorrhagic. So providers at a rural hospital without surgical services must A, determine the cause of shock before initiating the transfer process, B, repair all lacerations before transfer, C, obtain radiographs and treat all fractures before transfer, or D, initiate the transfer process when you suspect the patient has injuries that exceed your local resources. Okay, so it looks like most of you have voted and most of you are correct. You're going to initiate the transfer process when you suspect the patient has injuries that are going to exceed your local resources. That is extremely important. I would rather a phone call saying, hey, I got a really sick patient. I'm not sure why they're sick. I need them to come to you and get them here quicker, and sooner than later. You can do things to work the patient up and do things in your primary survey to control all the, the bleeding right away that you can, but you don't ever want to hold that transfer process up. All right.
I think you only have 3 questions.
Which of the following is true regarding compensated shock? A, cardiac output is normal. B, organ perfusion and tissue oxygenation is decreased. C, hypotension is always present. Or D, tachycardia is a sensitive sign in all elderly patients. So this one was a little bit tricky. The majority of you got it right. So the compensated shock, you're still in shock, right? But your body is compensating it. It's doing things to make those compensations for that, blood loss or whatever the reason for shock is. So your organ perfusion, your tissue oxygenation is still going to be decreased, even though your vital signs may remain fairly normal. Your cardiac output is not going to be normal, right? Your cardiac output, depending on the type of shock, is going to be increased or decreased. But your body is able to compensate with vascular tone and different things to keep your vital signs potentially normal. And that's what we would call like a compensated type of shock. And that's it.
Mike's going to run the
All right.
next part of the video.
Are they allowed to ask me questions now or after the video? I just want to make sure, yeah. No questions? Okay.
Always put
Thank you,
that
everyone.
from later.